Good day, everyone, and welcome back to another episode of A Lawyer and a Policy Analyst Walk into a Bar. I know it's been quite a long time, but we're back and we're hoping to stick around for a bit longer this time. As you know, I'm the lawyer, Jadwick
And
Cummings.
I'm Delano de Souza, the policy analyst. Like Jadwick said, we've been gone for a while. Over a year, by my count, Jadwick.
It's been over a
It's been
year?
over a
Oh,
year.
no,
It's
no.
been over a year.
Oh, man.
Everybody's been asking us what's going on, if the podcast done. All these things have been
Yeah,
happening.
nah.
So we have to get
Yeah,
back
definitely
to
apologize to everyone.
yeah. We have to.
Yeah,
We're at least gonna finish season 6, and then
yeah,
because
yeah,
we
yeah.
were 4 episodes in, and we took what was supposed to be the mid-season break, but just it never came back into being.
Yeah.
A lot was going on for both of us in terms of other priorities.
A lot happened.
Yeah. So, but we're back now, and we're here. Yeah.
We're back. We're back.
Yeah.
Yeah. Hopefully, you're gonna see our faces a lot more consistently, and you're gonna get back to your regular schedule podcast listening with us. So, we have a good topic for you, something that I think is interesting, something that affects the region, and like Delan said, this is episode 5, and we are calling this one "Paying Through the Nose: Health Insurance in the Caribbean." So we're discussing health insurance, how it works, different types of systems that are in place in the region. And so we're just gonna have a bit of discourse on that. Hopefully, get some comments later in the comment section. But Delano.
Yeah, for sure, man, Jadwick. Health insurance in the Caribbean is a big thing, particularly as the Caribbean region focuses on the ongoing cost of living crisis, which is really associated with high levels of inflation and lagging salary increases. One important issue that tends to fall through the cracks is the issue of the cost of healthcare, particularly as many Caribbean countries are confronted with aging populations and rising prevalence of non-communicable diseases and CDs. And so as those things happen, and as our Caribbean economies and our population ages, it becomes a question of how do we care for our older persons, the more mature persons within our societies. And of course, healthcare is a big part of that. And as a 2020 World Bank and OECD report, Health at a Glance, Latin America and the Caribbean, which we're going to be basing a lot of this conversation on, Jadwick, as it says, and it correctly points out, that a main barrier for accessing such healthcare services arise from out-of-pocket health expenditures, and we'll talk about that in a bit, which in the Latin American Caribbean region represent an average of 34% of total expenditure or total spending, well above the 21% average in the OECD, which is the Organization for Economic Cooperation and Development countries. So when we talk about out-of-pocket spending, Jadwick, it's important that we realize that's the amount of money that you have to spend out of your own pocket in terms of out of your income to pay for health services, as compared to, let's say, if an insurance company is paying, or if the government is paying and you're accessing the service for free. So that's a big thing. Of course, our willingness and our ability to access healthcare has to do with whether or not we have funds. Money talks. You see me? So if you don't have the money, you can't just show up. In many of these countries, and so that's a big part. So the current healthcare or the health financing setup in the Caribbean region is, generally speaking, the Caribbean, the government is the main provider of healthcare. That's generally speaking, primarily on a free or zero out-of-pocket basis, and we just spoke about what out-of-pocket basis means. So you don't pay substantial amounts to access healthcare at public facilities at the time of receiving the service. It's funded primarily through taxation. That's the general model. Of course, it varies from country to country. Now, this is typically the case for basic healthcare, but specialized treatment and purchasing of drugs and tests may come at an additional cost, although it's often subsidized depending on the country in which you're living or in which you're accessing the healthcare. And there's usually a system of clinics and hospitals across the country, polyclinics, that's as we refer to them in Barbados and in some countries, funded and run by the state and overseen, in some instances, depending on the country, by district or regional health authority corporations. And Jadwick, I know we have district medical clinics, our country is divided into districts in terms of that. I think it's the same for Jamaica, Trinidad. They have regional health authorities as well, and they would oversee the public health system in their respective jurisdictions or districts. Of course, undergirded by their respective ministries of health as well. So it's not that they're just acting in isolation or by themselves. So that's an important part of everything we're seeing here. So that's the current health setup. We know that we have these clinics, we know that they have these hospitals, and of course, this is the public system. We know that there's often a parallel private system where we have doctors that have their own practice. We have private hospitals in some countries. Ironically or interestingly, the persons who work in the public health system typically work in the private health system as well. And that can be a cause of some conflicts of interest, which I don't know if we'll discuss here, but it's a big concern sometimes where, you go to the public health system, and for some reason you end up in the private paying through your nose. And we've seen it, Jadrick.
Or the personnel that you might need, the personnel that you might need in the public aren't there because they're set up in the private system, trying to make more money that way.
And that's how it works. And there's often a conflict of interest there. So total budgeting and financing in terms of how the systems are set up. So, for example, there are some countries for which the tax or budget finances over 50% of all healthcare spending in those countries. In other words, the majority comes from taxation. Anguilla, Belize, Dominica, Jamaica, Guyana, Montserrat, St. Martin, St. Vincent. These are countries, Jadrick, as we know, where most of this expenditure comes in terms of healthcare, comes from taxation, comes from the government providing this. That's where most of it. Then we also have other countries in the region where social health insurance makes up more than 50% of the spending on healthcare. So, for example, and listen to the islands that we're going to call now, Jadrick: Aruba, Bermuda, Cayman Islands, Curacao, Turks and Caicos, Martinique, Guadeloupe. These are the countries where you have health insurance, or a properly organized health insurance system, where in many instances it's mandatory that you contribute to it, they take it out and so on. And when you go to the healthcare providers, you provide them with your health insurance, which is a national system. And in these countries which we just listed, this makes up over 50% of the spending on health expenditure. Then there are the hybrid countries where there's a more equal split in terms of the taxes, the provision by taxes, private health insurance, and out-of-pocket costs. And these countries: Antigua, Barbados, the Bahamas, Grenada, St. Kitts, Nevis, St. Lucia, Trinidad and Tobago, the Virgin Islands, and so on. Haiti, although in the case of Haiti, PAHO reported that most of that money for healthcare came from external funds. We do know of the humanitarian and social unrest and issues in Haiti, so that's not that's not unexpected. But for those other countries, and it's interesting to look at the perspective of St. Vincent, and it depends on how you look at it, because more than 50% in the case of St. Vincent is coming from taxes, from government expenditure, compared to Barbados, Grenada. And so a lot more persons have private health insurance, for one, than in St. Vincent, and a lot more persons are spending out of pocket. And so it depends on how you look at it. Some persons might say, well, it's a good thing that the government is providing so much in terms of the expenditure for health. But then if the services and the quality of services are limited, or not where they should be because of the dependence on government expenditure, and then you start to wonder about the quality of the healthcare system as a whole. You see me? So those other countries, for example, Barbados, we have parallel system in many respects in private healthcare, public healthcare, and so on. A lot of persons, significantly more persons have private health insurance, and of course the government provides through the QEH and to the polyclinics and so on. There is that public system, but by and large, anything you could do in the public, you can do in the private as well. And so that's how you see those countries being made up. But a big part of it we have to zone in on is that issue of private health insurance, which we're going to talk a little bit more of. Yeah.
But before you just to clarify, before you go into the system of private healthcare, the system as it's set up in Antigua and Barbuda, where you contribute, there's a specified tax. That's the system. That's how it is. Like, for example, in the NHS in England, like that's why that system is so robust in England, because there's like a dedicated tax that you contribute to the NHS. So it's a similar thing in Antigua.
It's a similar thing in Antigua. And I'll tell you a bit about Antigua. I was just at a health conference in Colombia recently. Antigua was represented at that health conference. The medical benefit scheme, as it's called. It's a special system. It's unique in the sense that it's a state health insurance scheme that they refer to as medical benefits, where the workers pay a special levy on their salary, and it's directed
Right.
into the fund. I think it's around 3.5% that is deducted in terms of contributions from the earnings of insured persons, and it's matched by the employer, similar to how our NIS is set up. Yeah. So
Yes.
medical
Right.
benefits offers financial assistance and pharmaceutical supplies to qualified persons on the islands. They also, some of the money also goes into the hospital. I think it used to be Mount St. John, but I think it's the Celeste Bird Hospital now in Antigua. But that's a closer model, like you said, to what they kind of have in the UK. Except in this case, it's not as well capitalized, and the rate
Right.
at which you pay is small, and it also, in many instances, not everybody is covered. So, for example, there's a lot of persons who might not be a part of the medical benefit scheme, whereas they should be. But you know how things go, similar to our NIS, which we talked about on the previous episode, and that's the reason why this episode is a good follow-up. Although we've been gone for a while, it's a good follow-up on that. Yeah. And that system in Antigua is actually what other countries in the Caribbean want to move closer to, where we have a national health insurance system where you contribute into it, and then you are issued with a card. The money is funneled into the hospitals, and then you're able to access. So you have a choice between private or public, both of which will be covered under the national health insurance system, like I said. So what you would see, similar to what you would see in more developed countries. And that's as Caribbean countries try to make this push for universal health coverage. Yeah.
So you think that's a system that's preferred, that we should be pushing for that kind of system across the region?
Well,
or do you think persons typically might say, well, why is this coming out of my taxes? Why is it coming out of my income? Why do I have to contribute to this? It's a similar thing, I guess, rationale with private insurance. A lot of persons who don't opt to have private insurance, in addition to money coming out of their income, they're probably thinking, boy, I'm strong, I don't get sick, like why do I need to pay for health insurance? But the fact that it's automatically coming out of your salary as a part of that system, do you think that like persons would be receptive to that kind of system, or push towards that system across the region?
Well, I'll say this: I see people know in terms of NIS. That's some of the concerns that we hear. I mean, am I going to get the pension and so on? But I think if asked, Jarek, if you prefer a pension or you prefer health insurance being mandatory, I believe more persons say health insurance, because the reality is by the time you get old, in terms of your pension, you don't want a pension, but you could do that privately. The amount is not very substantial if you think about it, but as you go through life and you get sick, you would want to know. I think the willingness for persons, it depends on a lot of factors, but a big one of them, for example, is if the medical benefits scheme or the national health insurance, as we might put it, if it allows you to access both private and public, and the public system, that works better. So as opposed now to having to have a surgical health plan, private health insurance, and so if the national health insurance also allows you to access the private facilities in the same way as you would access the public facilities, then I think the buy-in is stronger. That's what we've seen in other Caribbean countries that have that system, for example, where you choose where you go. You could go private, you could go public, but your insurance is still valid, irrespective of which one you choose to go. And so that's what we've seen. I think it's in terms of the overall, because I mean, if you think about it, and health economics is a big part of one of the courses I teach, for example, UWI. And pooling of risk is something that's very important in terms of insurance generally, where you have to the aim is to bring everybody together so as to you create a group of people who have different health characteristics, who have different tendencies to get sick, who different ages and so on. And the aim of doing that is to pool risk, so that if you might not be sick today, but there are others who might be sick, and then therefore they benefit from being a part of this group. And so that's the aim. But obviously, if the group is small, then the ability to pool risk and diversify risk is reduced. So the larger, and that's why the whole notion of the national health system is what's being pushed, because it brings together the whole country, and it creates a group with a diversified risk profile, or more diversified risk profile than, let's just say, us alone. Our age group, for example, Jarek. But if we have, the whole national population involved in it, then you're able now to have that diversified risk pool, where you bring all of the money together in one space, and then as somebody becomes sick, the money would go to them via their claims, and so that's the
Yeah.
aim of insurance generally. Point I'm making though is that the larger the larger the persons who are a part of the group, then the better it is in terms of cost, the better it is in terms of being able to manage the risk, and so on. So that's why most countries want to push in that direction, because if given the option, a lot of persons are going to say no. And who you think going to say no? The persons who are healthy. And if we're the one who say no, then it means now what are you left with? You're left with a pool of aging people who are likely to get sicker more frequently and are gonna drain out the funds. You get me? And so that's a big part of why that larger pool is desirable. Yeah. In the case of Jamaica, Jamaica's health system involves a mix of the public and private, like I said. So the public sector is the primary provider of healthcare and hospital services, while the private sector dominates ambulatory services, provision of pharmaceuticals, and so they also have a national health fund as well that contributes to specify in terms of its objectives, usually in terms of vulnerable segments of the population. That's what they focus on. The Bahamas, the government-backed healthcare system is responsible for providing the bulk of the healthcare to the population, but the Bahamas now has a national health insurance system that they're pushing forward with, and they were at the conference I was at recently in Colombia, and I was very intrigued at what they're doing in terms of that model that they're building out there in the Bahamas. So in the US, insurance covers about 84% of the population. That's a lot. Around 84% of the population.
Yeah.
If you try to compare that to the Caribbean countries, when we talk about, we know that there's provision in terms of the state, but that's not necessarily coverage in the same way. So insurance is different from the government being able to say, well, you could go to the hospital if you need to. Doesn't necessarily mean, that you have everything you need, the treatments and so. So 64% of that is private direct in the States, and that's for-profit commercial insurance, and there's not-for-profit insurance companies as well. There's also public, around 31% is provided by the government, and that's through Medicaid and Medicare, usually, again, vulnerable populations, the older, I can't remember which one, I think Medicare is for the older segment of the population. Medicare is for the persons who are below a certain financial threshold, and the government helps them to get health insurance in those ways through those two programs. Then a lot of the persons also have employer-related coverage, where your employer has a group plan, for example, and that's basically how it's set up in the States. I mentioned that because in my mind, I'm not necessarily sold on the idea. While I think it's aspirational and I think it could be great if we get it right, I think in the interim, what we need to start working on is we need to increase the number of persons who have private insurance until such time as we're able to get the national health insurance system set up in a way. Because that's important. I mean, Jarek, you have health insurance, I have health insurance. When we go and you do a procedure for $200 and you only have to pay $40, $20, it's nice. And not just that, and not just that, it allows us to get these procedures frequently, or as frequently as we would need to, as opposed to having to worry about that amount of money, that high out-of-pocket cost, and that's a big part of it. Yeah. So we have those challenges.
Something else that I don't have statistics or anything, but I think it just as a result of conversations with different persons who live in different systems. For example, friends who live in America versus friends who live in England under the NHS. The NHS is like the pride and joy of England, like, so to speak. Like a lot of Britons would praise it. But I think there's an interesting dichotomy that occurs between the two systems, because I think on the one hand, when you have the NHS and it's open to everyone and everyone contributes to that system in order to benefit from it, something happens where I believe persons, where it almost, how do you put it? Okay, there's a situation where I think persons feel entitled to it and obligated, in the sense that, okay, I'm already contributing to this from my salary, etc. I'm paying into this, and therefore and it's free for more or less, no matter speaking. So therefore, no matter what I'm feeling, I should be able to go to whatever hospital and get checked up and so forth. And present a situation where probably doctors, nurses, and so, because of the influx of persons that are always coming in or always coming in frequently, like they probably don't give you the attention that you might necessarily need, in a sense where they just give you a once over and say, all right, yeah, go about your way, because they need to get through people, because so many persons feel entitled to the system, they use it, as opposed to, say, in America, where insurance is everything. Like, insurance covers everything. You need insurance in order to be even seen in a hospital, and as a result of that, probably they give a bit more attention, in that they might try to run all these blood tests and do all these scans and everything, because they know that insurance is going to cover it. So it's interesting in the sense that like which system, because like both systems are kind of open to abuse in a way, whether from one part of this or not, like the public trying to go in and take advantage, or the hospitals and the systems trying to take advantage of the insurance companies. It's a interesting balance between, like, what would you want or would you prefer? Yes, on one hand, as a patient, like, you would want to have that free access, so to speak, to go in and get as much treatment or as you would require. Then the other hand is, would that result in you not receiving the care that you need? And it's, like I said, it's just interesting. That's something that I always think about in terms of when I have these conversations with different persons. So when you say, oh, we're moving to, or there's a push to that in the region, to a system similar to the NHS in the region, then that's something else that comes in my mind, because I'm like, okay, on one hand, our services aren't at the quality of the NHS per se, and then if we're going to try to kind of make it that way, and our person's going to feel entitled, always going to go, is the service going to be even worse than it is now? I guess that's something that I think a lot of the countries, as we begin to push towards it and roll it out, that's something that we're going to have to, like, bear in mind to overcome, because it is a problem as I see it in my mind. That's something that can happen.
Yeah. For sure, Derek. And I mean, they've already started. For example, in the NHS, over the years, they've become stricter. So they've had to increase the level of gatekeeping. So, for example, the focus on the GP, where in order to be referred to a specialist, your GP has to recommend that you be, that you see a specialist. Your GP should be your first point of contact in non-emergent cases and so on. So they've kind of been working on things like that so as to gatekeep. There's also capitation, which is basically where there's a per head cost per patient that is sometimes paid to the GPs and so on, depending on how the structure is. But all that is kind of meant to keep the cost at a level that makes sense. And also to, not give persons the freedom necessarily to walk in and say, well, I need this. There's a system of referrals from your GP and so on. So those are things that you kind of have to look at to see, how do we gatekeep? Because yes, we want it to be accessible, but we want to limit abuse, and we want to make sure, for example, that you're doing the best. And this brings us to something that is a concept that a lot of us don't really think about before we continue on to the high out-of-pocket costs. It's the whole notion of a queue, the line. You see me? The line. There's a whole topic that we teach in health economics that's called the economics of the queue, as it refers to healthcare.
Right.
Because think about it. If you wanted to go to A&E, for example, accident and emergency, the purpose of the queue there, if you go to the A&E and if you went there was no line and you could be seen immediately in the A&E, then the probability of you going for minor issues that could perhaps resolve on their own, increases. But if you know that if you go there, you have a half an hour wait, a little hour wait, then the longer you have to wait, the less likely you are to seek out accident to go to the emergency room for relatively issues that are not serious. And so the queue is important for that reason. Also, another one, the queue also determines, or it creates this split between those who go to the public and those who go to the private. Because think about it again. If you, as a person with health insurance, know that if you go to the hospital, you get a relatively similar quality of care, you don't have to wait, the line's non-existent, you're more likely to go to the public system than you are to go to the private system. a large part of why we go to
Mm.
our private doctors and these private clinics and so on is because we know we don't want to go down hospital and wait for no long set of time.
That's true.
We know
Yeah.
that we don't want to go in
A
the
lot of it's
clinics
just
and
waiting.
wait. We feel like there's better
Yeah.
ways to spend our time. So those with health insurance and so on, we say, well, let's go private. And not are those who can afford would say,
Yeah.
let's go private. So the economics of the queue or the line is a very interesting topic because it leads now to this and it kind of weeds out, and which is part of the reason for it. It weeds out persons who, one, are not emergent, who may not be serious, who don't need to go there, and two, it also does a thing where it filters out those persons who can afford to go private, and they go private.
Right.
Because that's important. Because
Yeah.
while the public facilities are there for everybody, in actuality, you would prefer if those persons who can't afford to go private dominate that space, as opposed to persons who are in there, taking up the space when they could easily afford to go private. So the queue does both of those things. The problem that we have is that when the queue starts to get too long, there are the disadvantages associated with a queue that's too long in terms of health outcomes, in terms of economic outcomes and social outcomes and so on. But we won't get into that. But suffice it to say that the economics, it's critical in terms of how these, because you want to have a system where, yes, it's you in and out. But in actuality, if you do have that, think about how many people would say, well, if we go down there, we're going straight to a doctor now. So we don't have to wait outside. You understand? So there's all of that in there. So like I say, the whole system of the whole field of health economics, and it's so interesting and vast. Things that we don't even think about.
It is.
Yeah, that we don't even think about. Generally.
Yeah, simple things.
Yeah, that queue.
Even things I was thinking about, like with that, like going back to the NHS again, like it's a similar thing. Like I guess like during the pandemic, just because like they were in a burst, it seems almost just because they had to deal with so many persons who had COVID-19, and then other persons who had things that they would have just generally gone for had to take a back seat because they just weren't allowed to occupy those spaces, and then you see yourself being forced to either seek a private practitioner, like you say, or just kind of deal with it on your own.
Problem we had again, when the wait becomes too long, persons' conditions worsen. Some persons die waiting for surgery and waiting for attention and so on. So the long and short of it, the queue can't be too long, as we just say. It can't be too long where it's having these kind of adverse outcomes. But a big part again in terms of whether or not you choose to go, despite irrespective of the queue, is whether or not you could afford to go out of pocket and go to the private. Right. So high out-of-pocket cost means that the population is directly financing a substantial part of healthcare when they need it, which is in turn which can push them into poverty as well and hardship. And that's the whole notion of health insurance generally, because the aim is for you not to go, slip into poverty if you get sick. That's a big part of it. In Latin America and Caribbean, on average, almost 8% of the population spends more than 10% of their household consumption or income on health, out of pocket. And that's a big part. The proportion is low in a number of countries such as El Salvador, thinking in terms of Latin America, so Mexico, Guatemala, under 2% there. But it is almost 17% in Barbados. Almost 17% of people in Barbados are spending substantial amount of money in terms of out-of-pocket costs. And I'll give you some statistics for the overall country in a bit. In addition, most countries have a low proportion of households spending over 25% of their income or consumption out-of-pocket. But Haiti is much higher than the rest. We'll talk about that. So high out-of-pocket costs mean some things. Let's talk about that. So high out-of-pocket costs means that the population is directly financing a substantial part of healthcare when they need it, which in turn can push them into poverty. The important part here, you paying tax already for healthcare now. Think about it. You're paying tax already, assuming that you pay tax and so on. But then when it comes now, when you need healthcare, you're still having to spend a substantial amount of that your out-of-pocket cost there. Exactly. So the thinking is, if I'm already being taxed, why not put that tax into a pool that we could then kind of like the NHS again? That's why the thinking is going that way, because some countries already, for example, have a earmark tax, which is a tax, basically means a tax that is set aside, and the revenue is supposed to go to something in particular. So in Barbados, we have a health levy that's administered to the NIS. there's several, like in Antigua, there's the medical benefits. In St. Lucia just introduced a health tax, a health levy as well. Although that's not necessarily earmarked specifically, the proportion, because it's supposed to be health and security. That's another political storm brewing in St. Lucia, which we're not going to get into. But suffice it to say, that's part of the thinking. Like, listen, this money is being collected already. What we need to do is pool it and use it more efficiently to manage the risk and to get more persons under insurance and healthcare provided for them. So according to the report that we mentioned before, the PAHO report, the proportion of households spending more than 10% of their consumption on out-of-pocket healthcare in 16 Caribbean countries is more than 10%. This excludes private prepaid payments because, of course, if you have private prepaid, you're paying your insurance monthly, annually, whatever the case. So on average, almost 8% of the population spends that amount. So the proportion is low, and like we said, in a number of countries. So let's start now about as a population level in terms of how much out-of-pocket cost there is. So, for example, in Antigua, 35% of the money spent on healthcare comes from out-of-pocket. It's a lot. 35%. 35% of the expenditure within the healthcare system comes from out-of-pocket. People paying their own money out of their own income. In Barbados, and this is an anomaly. I was at the PAHO meeting here in Barbados early in the year, and they keep focusing on Barbados because it's an anomaly based on how Barbados' system is set up, based on how much money the government spends on healthcare, based on the private system, how relatively good it is. 46% of expenditure in Barbados comes out of pocket, and so the health economists have kind of been racking their brain as to why. But one of the main reasons is that they find is that, listen, there is the queue. For example, persons prefer to go private, get it done quickly, get it done efficiently. There's also a perception of quality, and we'll talk a little bit more about that in the private compared to the public. So even if you have, the public system available, a lot of it is coming out of pocket, regardless. Even if you go public or private, a lot of it is coming out. Obviously, if you go private, more money coming out of your pocket, particularly if you don't have health insurance. Belize is 24%. Grenada is 52%, even higher than Barbados. I want to get St. Vincent because we're from there. St. Vincent is only 31%, which is interesting. Again, not surprising necessarily or incongruous, because if you think about it, over 50%, St. Vincent is one of the few countries where it comes from government expenditure. My area of concern for St. Vincent is more about the quality in terms of the provision and the range of services available to us without having to go abroad. In my mind, not even in my mind, I think most people would agree in St. Vincent that the certain scans, certain tests, and so on are not relatively available. Not just the other day we got MRI machine, for example.
Yeah, exactly. And I was gonna say just a few years ago, maybe don't quote me, maybe six years ago, that the government got dialysis machines. So before that, you had to go private, and people know kidney failure, diabetes, and so that's something that's so commonplace that in almost every other country, that's something that the government provides for. So we just started doing that maybe a few years ago, but you'd have had to go private before. And it was a very tall bill.
Hot. In Barbados has actually done a really good job of that in terms of dialysis through a PPP. Another conversation for another day, but we could probably talk about that off camera affair. Another important element, Jarek, is the population spending more than 10%. Now, really and truly, you should not be spending more than that amount that large proportion of your income on out-of-pocket healthcare costs. So in Barbados, 16 point.
So this is like so the individual spending more than 10%.
Yeah, more than 10%. So 16.4% of persons in Barbados spend more than 10% of their income. Imagine you making $1,000 and an average $100 going to your healthcare, out-of-pocket healthcare. That's a lot. And of course, that's different from your taxes that you already pay into the healthcare system. So that's why it's a concern. So when you add them up, it's actually more than that. I think Barbados has the highest percentage in terms of the out-of-pocket. But again, the range of services and so on available, sometimes there's a cost. But what does the high level of out-of-pocket expenditure, what is it an indication of? So one, like we mentioned before, the first one is limited free provision of healthcare by the state. So if you see most persons spending their money out of pocket to access healthcare, it usually says that the governments are not doing enough in terms of healthcare provision.
Right.
That's why I said it's kind of an anomaly, because Barbados spends a lot of money on healthcare. But it doesn't necessarily have to be that, and it could be a second one. So the second one is lack of quality in the public healthcare system, or even a perception. The third one is a lack of trust or confidence in the public healthcare system, which ties into the second. So if you don't trust it, you prefer go private.
Yeah.
Yeah. If you don't want to go down Milton Cato, you prefer go. I was going to call it, but
that's linked to the quality.
That's linked to the perception of quality.
So
inefficiencies in the public healthcare system, for example, long wait times. That can make persons, I don't have all day to go and sit down and wait until they could see me there. I could just go private. And also, and this is the one that we're really focusing on, the fifth one is low private health insurance penetration in the country, where yes, you don't want to go public, but you prefer to go private. Problem still exists, because even though you're going private, you're spending that money out of pocket as opposed to private insurance. Yeah, because you would want, it's not necessarily a problem with going private, it's fine, but you ought not to be paying that money out of pocket. You ought to be covered by some form of insurance mechanism is what we're getting at here. Yeah. So given all of this, an important question often comes.
Jarek. I was gonna say, going back to 3 with trust and confidence. That's trust and confidence also in the other sense, in terms of confidentiality, because you might prefer to go to a private.
That's a good point,
health practitioner in terms of.
You feel like your business ain't up on the street. Everybody have a see around the hospital, and so on. Yeah, people.
Especially for the smaller islands and so everybody done hospital.
That kind of comes back to it. Well, not in terms of confidentiality, because in reality, the doctors at the private hospital are usually ones at the public hospital as well. I think it's more a question, you don't want people see you in there, or people might say, hey, I said she go to the specialist there, he go to the specialist, there's something like a guy now where he, as opposed to the private thing. It's a perception. We're funny people.
But then but as you said as well, that the same doctor would be the same one at the public. But to my mind, what comes up to me is probably the legality in terms of, if you go to that doctor in a private setting, they probably feel more of the burden in terms of, okay, if this information gets out, I could be personally
it's you.
Whereas, exactly. Whereas, when you go down to any public setting, it's like, well, is the government paying for that anyway? If they sue me, is the government this way, not me. But
that's a good point, because that's what a lot of them do. I mean, a lot of the doctors complaints all the time where the doctors waste the resources of the government. Some of them doesn't even, I don't want to cast us, but that's those have been complaints that we hear every year. Doctors are channeling patients to their private facilities. Some of them doesn't even have surgeries in the public facilities using public resources, but they're being compensated privately. Right. So those are things that the governments have had to look into over the years. That's important. So I mean, given all of this, an important question that often comes up in the Caribbean space is whether this system should be pushing for more private health insurance, like you said, or a public universal system of health insurance, which is managed by the states, to which our workers should contribute. Again, when we think about the public system, when you think about the public system, a big part of the reason for that is risk pooling and diversification. If everybody's in there, you're able to manage that money in a large pool, as compared to if you have private insurance, where you have a limited pool of persons who are operating within that pool, and it's not diversified enough. Quite often you have a lot of young people, not enough. So sometimes it's going good for now, but later on, when everybody starts to get old and start to get sick at the same time, then you see insurance premiums start to jump up, because they don't have the diversity in terms of the risk pool that they would like. So generally speaking, the approach which seems to be preferred in the option in the Caribbean space is to move towards achieving universal healthcare through a system of national health insurance. So for example, discussions have started in several Caribbean countries, including Barbados. St. Kitts is supposed to roll out theirs pretty soon. They're working with PAHO, Pan American Health Organization, and so on. They're at the cusp of launching theirs. Belize has already launched theirs as well. The representative from Belize was in the conference, the Health Economics Conference I went recently, and they're saying that they now want to move more north, I think it is, and then so they're expanding this, but it's already started. Bahamas has already started theirs as well, and they're expanding. They say that they've already hit critical mass. The point I'm making is that seems to be the direction that they want to go.
Right.
Yeah. Of course, and the other conversation is about what such a system would look like in terms of the design, the health packages offered, and how it's going to be financed. Now, a critical part of whether or not you decide if you're going to public, private, and how the system unfolds is the sort of package that is included in this national health insurance. So is it just, a small limited services? Does it include medication? Does it include drugs and so on? What is that basic healthcare package under the national system going to look like? In some countries such as Bermuda, the Bahamas, and so they have a very comprehensive package where almost everything that your private insurance would cover in terms of the relatively common treatment is covered by the public system, which is good because it then incentivizes persons to come into the public system as opposed to the private system, and it increases competition in that way. Because if it is that you have a package in the public system that is far below what is offered in terms of treatment, in terms of the scope of that package compared to private, persons are still going to prefer to go private. That's the reality of it.
Of course,
so you would want to get a package, a comprehensive enough package that is attractive to persons, to get persons enrolled in that, and to get them.
It's comparable.
Yeah. And that does two things. It gives people the confidence. You don't complain too much if you have to pay a little bit more, because you recognize it's almost a substitute for a private healthcare plan. And we've seen a lot of success with this across the Caribbean space, where you've had persons and Latin America as well, where you have that very comprehensive basic health insurance plan offered through the state provider, which is good. Yeah. And how it's financed is also important, because you want to make sure it's not too expensive, it's not taking too much of person's income, that employers are able to contribute and still remain in business, because typically the employers pay more than what the employee would pay in terms of their contribution. So you want to make sure it's not equitable necessarily, but that it doesn't hamper employment or hamper business development as well. So this is largely being done in collaboration with the World Health Organization through PAHO, which is our Caribbean and Latin American branch, Pan-American Health Organization. So while governments encourage those who can afford to purchase private health insurance, particularly for more serious diagnoses such as cancer, organ failure, and so on, the prevailing sentiment seems to be that the state will continue to bear the burden of marshalling finance for healthcare. And in my mind, it's useful because, again, critical is risk pooling. You don't get this sort of adequate risk pooling if people are going private, because you get people being insured in pockets, and so the risk profiles of these persons are not diversified enough so as to be efficient. Yeah, you can't have it everybody getting sick at the same time. You have to have some old people, some young people, some middle-aged people. You have to have some people who working in more riskier jobs. There are some people working in office. You have to have a pool there that is representative and that gives you the best possible chance of paying money out to those who are sick now, but still having enough left back so that when others become sick, you're able to treat with it and your liquidity isn't threatened. But if you have a lack of diversity in your pool, if we are 100 people in a group insurance policy, Jarek, and all of them 60, needless to say, it's one or two things.
Trouble.
Either that insurance policy didn't last in no time, or the insurance premium high. And that's another thing about diversification. Correct. Because as you diversify your pooling, it allows you to keep a relatively low premium associated with it, because you know that at any given point in time, it's going to be a relatively low percentage of persons who are sick and who are using the services, as compared to if you have a sick group that is insured. Obviously, the premium has to be high, and in order for it to make sense. So that's why that the idea of a national system, it augurs well for us in our space, because we have an aging population as well. So if that aging population were to seek out private insurance, for example, if they don't already have it, you could see that is going to be problematic. Yeah. So that's a big part of it. Yeah. So yeah, Jarek, as we start to wind down, we first episode back, so people don't know it can be a little bit long. We have plenty to talk about. You see me? Yeah. So let me zone a little bit on private health insurance. So what is private health insurance or medical insurance? Health insurance is an agreement in which an insurance company agrees to pay for some or all of your medical expenses in exchange for a monthly premium. It doesn't have to be monthly, some could be annual. Depends. Health insurance agreements generally come with exceptions to coverage, including a deductible that requires the consumer to pay certain healthcare costs out of pocket up to a maximum amount at the start of the year. All of we just hate deductible time. When the year start, Derek, you ain't getting 20%. You have to pay like a 40 or 50% because you have to pay a deductible when it starts. That's part of it.
Right.
Yeah. Then you have the co-payments, which are the part of it now that require the consumer to pay a set share of the cost for specific services. It's usually a 20 to 80 ratio. So you usually pay 20% and your insurance company will cover 80. Of course, that varies based on the insurance company. It also varies based on the procedure or the healthcare service that you're accessing. And there's also co-insurance, which is the percentage of healthcare costs that the insured must pay even after they've met the deductible. And until they reach the out-of-pocket maximum for the year. So there's those parts there. So insurance plan with a higher out-of-pocket cost generally have smaller monthly premiums, and that makes sense. Yeah, because if you're paying 50%, if it's like a 50-50 split, you can't expect to pay the same high premiums. Obviously, if you have a 20-80 split, then your premium is going to be a little bit higher. Yeah. So the cost of insurance plan in the Bahamas, for example, which is arguably one of the highest in the region. And I thought that the Bahamas one was high, but when I was at the conference the other about that, the man tell me about Bermuda. Man them said $2,000 a month and thing for health insurance. I said, you lie. I said, cannot be.
For health?
Yeah. I said, cannot be.
That's crazy.
Yeah. So it comes at a wide cost. Was it per month or was it per year? So don't quote me, but I know they say it was like $2,000, and I said, well, it can't be. But I also have to remember the population of Bermuda is small, and so there's that. But I was like, what? I was like, well, that's crazy. But in the Bahamas, for example, you could get the basic inpatient only plans. The inpatient only plans, you can get split as $54 a month, which is on par, 54, 100 and something EC. Yeah, 100 and 100 Bajan, around 130, around 140 something, almost 150 EC. Yeah. So while the most comprehensive plans with high limits and high benefits can cost us, and that's what you see, Jarek, I ain't lie, can cost as much as 1,000 about 1,000 Bahamian, because Bahamas and US is the same, 1,000 US monthly. It's crazy.
So that's over 2,000. That's close to
3,000. That's about 90% of people in Sylvan ain't making $4,000. You get me, bro?
No.
So it's like, you understand?
And even if they're making like 10 or something, for them to think, nah, I give you 3 of it, exactly. 3 of my 10 to.
But, and particularly when you weigh the odds, when I say relatively young, of course, those are the plans that have the really like catastrophic injuries and big payouts and so on. They cover almost everything you can think of. Those are those expensive ones.
As it should.
Yeah, and ideally that's what all we would want. We would want that if, God forbid, we get a heart failure or something that, insurance kicks in and sends us where we need to
everything
go. Everything is covered. But that's not our reality. An important point I want to highlight, Janik. So in an ideal world, healthcare providers should accept the insurance card issued by insurance companies to the holders of medical or health insurance, which provides them with the benefit of only paying, or it should provide them with the benefit of only paying their co-payment, the portion which they have to pay of the bill. At the time they're accessing the service, with the insurance company paying the balance directly to the provider at a later date when the claim is filed. However, in the Caribbean space, most doctors' offices, private clinics, laboratories, dentists, they require the patient to pay the entire bill at the time of service delivery. I don't think there's most of our listeners can relate to that. And then you file you do the little paperwork, and then you wait to be reimbursed. This is a significant problem in our Caribbean space, and it was interesting, and I'll talk about that in a bit. This is a significant problem for lower income persons with health insurance, because you have health insurance, and that's supposed to protect you from these high out-of-pocket costs. But if you have to pay at time of delivery, then the insurance almost becomes moot, because think about it. particularly those whose insurance coverage is provided through their jobs. For example, you might be working at a company, your income isn't the highest, but you have group health insurance through your company. Yeah, you
Yeah.
have insurance, but you don't have the income to go and pay $400-500 or $200-300 to see the doctor to do a procedure to run some tests. And to the extent that you have to pay up front, it means that you might not be able to access it despite having health insurance, which is
Yeah.
madness. It don't make no sense.
Yeah, that defeats the whole
Yeah,
point. Yeah.
defeats the whole purpose. So they simply do not have the money to pay the 100% at the medical costs up front and wait to be reimbursed. And of course, studies have shown that that has been detrimental to their health outcomes, because you found that persons with health insurance who can't access the service because they have to pay out of pocket up front have poorer of health outcomes than others. And that's not surprising.
Right.
So governments may need to intervene from a policy perspective. Now, while I was at this conference in Canada, I keep mentioning it because it was such an enriching experience, Jarek. This is one of the things that I mentioned as an academic. I said, well, listen, we've all been highlighting all of these issues that we have with respect to the healthcare system. And one of the big ones that I see that at the grassroots level that needs to be addressed is this whole notion of having to pay out of pocket and then being reimbursed. The gentleman now who's head of the national health system in Bermuda, he stood up and he said, what? He said, that happens? He said in Bermuda, the government has actually passed a legislation which prohibits healthcare providers from requiring payment at delivery where persons have shown proof of insurance. So once I show you that I'm insured, you can't tell me nothing about paying 100% upfront.
Yeah.
I pay the part that is required, and then you claim for the rest from the insurance company. That makes sense. I've been calling for that across the region now. And I think now that I've seen it done and that's another benefit of these conferences. Now that I've seen it done in Bermuda, I'm going to be pushing. I'm going to say we need to pass this piece of legislation. Now, interestingly, and this is what I asked the gentleman from Bermuda. I said, well, listen, it's a two-sided problem. The first one is that you have to pay up front. The second one is that the reason why persons or health providers don't want to allow reimbursement later and upfront payment, that's because they require is because they worry about delays in terms of what they experience with getting their money from the health insurance company. Yeah, the guy from Bermuda said, we thought of that. He said, we thought of that. So the piece of legislation, I actually got him to send me legislation so we could then, I've read the legislation. I was like, this makes so much sense. Why can't we adopt it across the Caribbean space? I'm going to be pushing for that now. I want to write the paper on that, and so we're separate. So the Bermuda law actually establishes a maximum time period of 1 month by which insurance company must settle claims. So the health providers, the maximum they could be out of getting their money is a month by law. And he told me actually that in the island, the majority of claims are actually settled between 1 to 2 weeks. So those claims that actually get close to 1 month are actually in the minority. And he said the system works, the law works. And I said, and people, other persons in the room were saying, listen, why haven't we thought? And in my mind, I was like, it really is a common sense piece of legislation. We see a problem, it's an easy fix. Prohibit them from turning away people with health insurance unless they can pay 100%. And at the back end now, you tell the insurance companies, well, listen, you have this maximum amount of time in which you have to settle this claim, or else you're going to run afoul of the law. Of course, it has penalties and so on and so forth that are associated with it. But it's an interesting piece of legislation. And I said, well, common sense. And I can't see why we haven't been able to do that in our space. You
see similarly, what I've observed is this, because obviously without legislation, it's discretionary at this point. But I do know of private health professionals, healthcare providers, that they've streamlined their process in such a way that their relationship with the insurers is such that they do get reimbursed so quickly that they would actually allow their patients to, once they know that their patients are covered, then that's fine, because they have streamlined that process in terms of recouping the monies from the insurance in a way that's seamless for them. So, for example, like in St. Vincent, the dialysis provider, the private dialysis provider, Healthcare Health Solutions, I think, Inc., they have that process down packed. So they basically allow the dialysis patients to come in, receive treatment, and they just deal with the insurance later. So at least yes, it's discretionary, but at least some healthcare professionals are going above and beyond to ensure that the individual doesn't have to worry about putting up the money up front and then reimbursement and all that
But
kind of
and
things. But yeah, obviously legislation would
but
make
I
that
mean, Jarek, if you watch
all
it,
the
if
better.
you really watch it, if it is, and give it the example that you use, it's not cheap. So if they didn't allow
No, yeah,
insurance, if they mandated everybody pay 100% upfront, those clinics will be empty. So it's
oh
also
yeah,
in their best
oh yeah,
interest.
oh
Yeah,
yeah,
you get me? But if you're thinking about small
yeah,
things like
yeah,
medication and a little blood tests and a little doctor's visit and so,
yeah, yeah.
to them, it's not thing. But I do take your point, because in the absence of legislation, persons have found means of streamlining their processes to make sure that the
But that's
person,
the thing.
yeah.
Yeah,
But it
it's about streamlining it to
and
ensure
it
that they
should
aren't,
not be
they
that
don't
way.
feel as though there's a
I
delay
don't
and all that.
understand why the
Yeah.
governments across the Caribbean space have hesitated in this and continue to not see that as a priority. And like I said, everybody in the room was surprised when Bermuda said that they have that legislation on the books, and it works.
Yeah.
And it's similar to Obamacare as well, because that's one of the things that some of the things that
Right.
they wanted to do. So big part of that. It's very difficult, Jarek, to get statistics to the number of privately insured persons in our Caribbean space. The insurance companies are very cagey when it comes to that, obviously market share and so on and so forth. But we know that out-of-pocket costs, we know that a lot of persons who have the proportion of persons who have private health insurance in the Caribbean space is in the minority. That's a fact. If you
Right.
really think, if you do a random survey in Kingston, Bridgetown, Georgetown, Kingston, if you do a random survey and you ask people who have private health insurance, and I don't think you'd be surprised that the majority are gonna say, no, we don't. Yeah. So how do we increase the rate of private insurance penetration? Yeah. So some advocates for health reform have little faith in the Caribbean government to be able to organize and expand a nationally run system. People say about the government is Marby shop, generally. You see me? So I don't really feel like this thing happening anytime soon. You get me? So that's what they've been saying. Yeah. Several states, So because of this now, they said, listen, we don't expect this thing to happen in 5 to 10 years. So we should ramp up private health insurance. So they advocate for that, some persons. So private health insurance mandates, or employer mandate, is a big part of some. This has worked to varying extent in the US, for example, where if for certain companies, if you have a certain number of employees, you have to have a group provided plan for them. So that's basically what a private insurance employer mandate is. So basically, where employers are mandated to provide health insurance for their employees, several states in the US have implemented this, like I said, with varying degrees of success. And it's usually applicable to companies employing over a minimum number. So in our Caribbean space, with small enterprises, might say 20, 30, how much ever. Once you have that number, once you meet that critical mass, you have to provide insurance. There's some pros and cons. So usually some form of tax deductible benefit is provided to the employer in exchange for providing the health insurance. So there is some tax incentive, some benefit, and it removes the choice of having coverage from the employee. You understand? So that's an important part, because if left up to their own devices, yeah, some employees are not gonna have health insurance. We know that. Yeah. So what that mandate does is that it makes it mandatory for them to have that. So the employee often does not have to contribute to paying for the policy. So a lot of companies, it's non-contributory. Have benefited from that, where you don't pay towards your health insurance plan. The company does 100% of it, which is great. Right. Some cons is that loss of insurance when you leave the job. So when you leave the job, that happens. I've left jobs and I've lost my insurance when I've left those jobs. So that's a problem with having your insurance provided by your company. Limited choice in terms of how the insurance plan works. I've been in jobs where fellas just jump up and say, hey, nah, we're changing from Sagicor and we're going with Najicona. Say, I like Sagicor, but you don't have no choice.
Yeah, like you have no choice.
You got me, because it's dealt with.
So maybe there's something else that could come in terms of with the legislation, because some insurers, they offer, they have what we call a portability provision. So it usually happens with group insurance for life insurance. It doesn't really happen for health, but they have a portability provision, which is, your right to convert it to an individual policy after you're fired. So you'd have a group life insurance with the business, but yeah, you're fired within a set period, then they would automatically convert it. Well, you apply, but they would convert it to an individual policy so that you just aren't left like that.
Yeah,
So maybe if they bring in a legislation in first place to implement some of these things,
that might
then
something you need to
maybe they could
contemplate.
report yeah, like a mandatory
Yeah,
report bills
yeah.
provision, something like that.
Yeah,
But
because I've
yeah,
had that experience where I've left jobs and I've lost my insurance when I leave, and so that's why now standard practice now is to have the health one provided by the company, but you have your private one, your individual one, which you maintain, but it's expensive.
yeah,
It's expensive, and then
it
it
is. Yeah.
sometimes you're paying that every year, and you don't claim on it. For example, you keep claiming from the employer provided one, and so then you start questioning, like, do I really need all of this? I mean, it's fair to say until you get sick. So that's the thing. Just go, yeah. So it
Yeah,
has been
yeah,
argued that employer mandates lead to reduced wages for workers because obviously, if I have to pay private insurance for my workers, then I might not want to pay them as much money. That's what we've
that's
seen.
much.
That's been
Yeah,
some of the arguments. So it increases unemployment. That's one of the arguments against it as well. It increases unemployment as companies reduce the number of workers they hire because every additional worker you bring on, you gotta think about an insurance plan for them or including them in your group plan and so. So one of the arguments is that
that's
you're
true.
gonna think twice
And then you
about
hire
hiring.
premiums and all of that.
Yeah, you're gonna think twice about hiring an
Yeah,
additional worker. Um,
and meeting the threshold as
eh,
well. Like if there's a threshold for
Exactly.
10
So if
people,
it's
you say,
if you're
well,
at
let me stick to
9
9.
and if it's 10, you say, well, we ain't
Yeah,
going past 9 now. We ain't going past
yeah,
9 unless I absolutely have. I rather get overtime, double time. I'm not going past.
yeah.
I'm not going past that. Yeah. A
Yeah.
2012, a 2011 study by Buckmuller et al. I hope I'm pronouncing it. In a study of employer mandates for health insurance in Hawaii, they found no statistical significant support for the hypothesis that the mandate reduced wages or employment probabilities, which is important because it counteracts those narratives that we just mentioned in terms of reducing employment and reducing wages. They found that, listen, the employers aren't that concerned about it because one or two workers additional don't really change the premium and so on and so forth. Instead, its primary detectable effect was an increase in reliance on the exempt part-time workers, and that's an important part. So this part still focuses on employment, but differently. So as opposed to hiring full-time workers, the law in Hawaii exempted part-time workers from being counted as part of your overall head count. And so instead of hiring people full-time, what the study found is that they
Just
start hiring a
hire
lot of
part-time.
part-time workers so that they remain below the thresholds.
Right,
Yeah.
right.
And so you have to be conscious, and that's why these type of studies are important in terms of what academia does. It show them clearly. Now, if you're designing a piece of legislation now surrounding employer mandates, then you have to now think about the role of part-time workers, whether or not they should be counted as part of the
That's true.
full-time complement, and so on and so forth. So a lot of nuance there. Yeah. So that's the first one in terms of increasing private health insurance, which is the crux of what we want to talk about. Although we've been all over the place and back. Yeah. But
Yeah.
greater organization and use of group plans is another way to increase private health insurance. So some have argued that if we're able to get certain groups of people workers together, we might be able to insure them as a group. So for example, farmers. So we have a lot of farmers, but they're not necessarily in a group. Yeah. So for example, some countries have gone the route of creating farmers co-ops. Yeah, or to the Ministry of Agriculture, where you bring these self-employed persons together and so on as a group, and then you have a group insurance plan that would then apply to them. And that's a way to increase private health insurance, because one farmer by himself isn't going to think necessarily he needs insurance. But if the Ministry of Agriculture, for example, is able to get them together in the form of a co-op, I think some countries, I think St. Lucia, for example, that's not health insurance, so they have insurance. They have an insurance policy for crops that if they have bad weather and so on, that they have basically business insurance for farmers. But my thing is, I believe that you could use that same model which you've used to bring them together to insure their produce, to insure them, that insure their health and their lives.
Health insurance.
So that model, I think, is transferable in that respect. Yeah. Third one is to expand the limits for health insurance coverage and benefits. So, for example, under Obamacare, the Affordable Health, everybody's called Obamacare, but it's actually the Affordable Care Act of 2010 has prohibited insurance companies from denying coverage to patients with pre-existing conditions. That's a big one. Yeah. And if you think about that, there are a lot of persons who would not qualify for insurance know that if you were to pass legislation like that, that would then have to be covered. Yeah. However, there's some potential fallout to it, because if you have to cover these really sick people now, then premiums for everybody else might go up. So there's that, but that's a caveat. And it has also allowed children to remain on their, and this is an important one, it's allowed children to remain on their parents' insurance plan until they reach the age of 26. In our space, I think you have to be less than 21 or 18, or less than 18 to count as a dependent for insurance purposes as a child. Yeah. Right. So if you're younger than that, if you get past that age, I think it's 21 or 18. Don't quote me on it. I try to remember. Of course, your wife could be a dependent for as long as, but in terms of the child, it stops at maybe 18 in some countries, 21. Yeah. But the Obamacare raised it to 26, which is interesting because it allows you to remain at a critical junction in your life. It allows you to remain on health insurance while you're in university. Because when you're in university, you don't have income. So you don't really have the ability to afford private health insurance. So by pushing it to 26, your university years are now covered under your parents' insurance as a dependent, which is something that we have to look at in our space as well. Yeah. Because during that, you don't have an income necessarily in college, in university. So I think that's something that we could look at as well. So in addition to these changes, the Affordable Care Act, Obamacare established the federal health insurance marketplace, which is another interesting one and this is the marketplace which individuals and businesses go to shop. It's an online platform when they go to shop for health insurance. It brings everybody together, offers competitive rates. It was supposed, and I think it has, I haven't read the study on it yet, but it's supposed to have increased competition in terms of rates, so as to be able to get everybody in the same place selling. The silos don't exist where you're being tricked into thinking you have a good plan when you really don't have a good plan because that person over there isn't, so that centralized place of sale, marketplace, allows you to compare rates and get insurance relatively easy. And of course,
makes sense.
So that's basically what I wanted to cover for our listeners. Very important, something I've become very passionate about over the last couple of years, Jarek, in terms of health economics, health insurance in the region, healthcare provision in the region. I think we have a long way to go. I think we have I think we are operating in silos in terms of our Caribbean space. We were at this hospital, as I'm wrapping up. Guys, I'm sorry, I'm wrapping up. But we were at this hospital, the conference in Colombia, and I can't talk about it enough. It was at this massive international hospital. We did a tour of the hospital, Jared. Man, them just an MRI machine here, thing there, CT scan there, the beds and them thing, everything just pristine. And the guy, and what I didn't know, which was interesting, is like it's called the International Hospital of Colombia. 46%, I think, if it's the number, don't quote me, I think around 46% of their international patients come from the Caribbean. And a lot of patients actually come from the States. They are one of two countries in Latin America who has certain robotics. Them have robot and they're doing surgery and thing in a Jadrick. I tell you, it was eye-opening. I was like, you would not expect, like, typically, unless you know, we wouldn't expect to have that in Latin America. And increasingly, our patients in the Caribbean are going to those specialized healthcare centers in Latin America because it's significantly cheaper than the US. They have a fully bilingual team in there. I was blown away, bro. And one of the persons kind of, I was talking to somebody from the conference, and we were kind of not laughing at, but we were kind of realizing that these type of hospitals are benefiting from the fact that we as Caribbean people can't work together. Because the argument is we only need one of those hospitals in the Caribbean, bro. Just one, or maybe two. One for the north, one for the south, and we good. We don't need these type of them fellas. Then they're doing pig transplant and thing in a Jadrick. Them man doing, like, seriously. We walked to the place and I said, what?
Like
yeah, bro, like cutting edge.
Yeah, like organs and stuff.
Yeah, they're doing like animal thing. And I'm like, and if we only need minimum of one of those type of hospitals in the Caribbean space, they call them centers of excellence. If you could have one, fellas doing heart transplant, kidney organ transplant, everything right there in that space. And it's crazy to us because
I wouldn't even think you would. You wouldn't even think of it.
No.
Yeah.
No.
Like like until you're telling me now, I wouldn't have
It's
fathomed that that's all
it's
that's happening.
becoming
Yeah.
standard. And what I realized in the
Yeah.
conference is that most of the countries there who are represented at the conference, they already have a relationship with that particular hospital, and they send the bulk once the care
Okay.
can be offered in their country. That's where they send them. A lot of their patients are going there, and the health insurance providers are saying cheaper, standard of care is excellent or sometimes even better. The hospital is in
Right.
it's in what part of the mountainous place in Bucaramanga in Colombia. So they say the altitude is better for recovery. But I didn't feel so relaxed. I was there for like 2 weeks, bro. Like you just wake up and miss just blink.
Can you imagine?
I'm
Yeah.
telling you, bro.
Yeah.
We're wrapping up and that's it, and I'm done. But I'm just saying, in our Caribbean space, we could do so much better. And we need to start operating in silos, and we just need to work together. Because imagine, Jarek, we're talking about pooling risk. We're talking about pooling risk in a country of 110,000 in St. Vincent. What if we pool risk in the 17 million or so? That if we bring together the Caribbean space,
Across the
then
region.
think
Yeah.
about our risk profile then. And that's how Colombia has benefited, because they have a national system where all those millions of people, everybody pays into a set system. There's one big, massive, multi-billion-dollar fund, which then is used to fund their health insurance system. And it's crazy.
Right.
There was a presenter who broke it down. I done.
I know you could go on further about it, because I know how passionate you are about the topic as well. But yeah, no, it was a good topic to discuss. I think hopefully our listeners learned a lot, our viewers learned a lot. I did. Even though I'm co-host as well, I learned a lot. I know that I could go on and talk for a long while about this, but we're back, and hopefully we're more consistent. Like I said, everyone, please subscribe.
Watch out, we rusty.
Listen.
Because we ain't even raise the glass.
We skip, yeah, we skip.
We rusty.
Now,
raise the glass.
I see your eyes go down to a glass, and then I remember.
I did forget doing a guy. No, I say, hold on, but we ain't even raise the glass. Let's raise it. We're drinking to Derek.
Oh man, it's been so long. I mean, so many things happened across the region. A lot of things happened that we should have been raising our glass to for the past year that we're missing, really. But I think I'll just raise my glass to something personal. To my co-host getting married. I can't think of anything else. There's more important right now when it comes to our podcast. So congrats to you. We had a lovely experience. It was a lovely destination wedding, and so
for sure.
And all our friends came together, and it was a really good experience. And so gotta raise our glass to that. Bro. His lovely wife as well. She has her own podcast, which we would plug from time to time. It's called Built In 101. Definitely gotta raise our glass to that.
I just want to raise my glass to friendship. A personal thinking it from you. Friendship in terms of the important people in your life, and recognizing that from time to time trials, tribulations happen in life, and having people to lean on is so important. Having all you guys there with me as I celebrated and took that step, it meant the world. For you guys to have traveled all the way to Mexico to spend some time with me in that way, it meant I just want to raise my glass to friendship and solidarity. Yeah,
definitely.
For sure.
Yeah, that's an important one. Definitely. So, guys, that brings us to the end of another episode. Like I was saying, subscribe wherever you're watching, listening. You can listen to us everywhere. You could watch us on YouTube. Make sure to subscribe, like, and as I say, ring that notification bell. This has been a lawyer and a policy analyst walking into a bar. I've been your lawyer, Jadwick Cummings.
And I'm Delano D'Souza, the policy analyst. Catch you next time.